So, hello and welcome. And we're going to just talk about Medicare 101 or the beginner's guide to Medicare and the basics. Now, we will be answering questions. If you want to save those toward the end or type them into the chat box if you're able, Raquel will be paying attention to those for us. She's helping me out, and she will be able to interrupt me with any kind of pertinent questions that come up at that very moment. Otherwise, we're going to try to hit every single one of those. So the main thing that we want to talk about today when we talk about Medicare is that this is what we do. We pull people to the 50,000 foot view and say that for most of us, there's really only two choices for Medicare. Sometimes you might have a third option, someone who has VA benefits, or maybe they're a retired state or federal employee. For example, I just talked to someone this morning who has the state benefit health plan because they're a retired teacher. So sometimes people have a third option, but for most of us, it's either option number one or option number two. And that's how simple it can be from the 50,000 foot view. And that's sort of what we're going to go over today. So moving on into page 2, this presentation, I have to say this, is for educational purposes only. I'm not allowed to talk about the specific benefits of any particular plan. Medicare has strict rules about that. I am not employed by Medicare, and I am presenting as a public service. Complete information you can always get, of course, by going to www.medicare.gov. And additional education flyers, we can make those, they're all available at our website, but we can also send those to you in a PDF format for additional information on any of these subjects today. So when we talk about Medicare, one of the original problems is that, of course, they didn't have a healthcare policy that was available for seniors at retirement or for people of Medicare age. So they created Medicare, and it started in 1965. Federal program, of course, run by Medicare and Medicaid services. The thing that I want to emphasize, of course, is that it's not the same as group health insurance, the Affordable Care Act, veterans benefits, or even Medicaid. The thing that the biggest challenge that they had is that it was created in 1965 and they didn't have a crystal ball to predict the future. So things have changed a lot, and there's been a lot of various adjustments to it and overlapping laws that create some of the issues I think that people have with it today. So there are 3 types of eligibility. The most common one is, hey, you turn age 65, and you are a citizen or spouse of a citizen who has worked for 10 plus years, you qualify for what they call full Medicare benefits. If you're under age 65 and you've been on Social Security disability for at least 24 months, then you're enrolled in Medicare at that point. And then the third option is if you have end-stage renal disease, which means you're on the kidney transplant list, or if you have ALS or Lou Gehrig's syndrome, that's something they've added in the past couple years, then they'll put you on Medicare at any age as well. So these are just adjustments that they've had over time. I mean, when they first started in 1965, it was just anyone who turned age 65. And they've added the type 2 and the type 3 over time because they had some eligibility issues for people who, what if they were disabled and they weren't able to work, or if as soon as you get end-stage renal disease or ALS, most people are done working almost immediately. And that's why they've had to slowly make those adjustments over time to be able to help people get the coverages that they need. So when we talk about Medicare, most of us know this, it's Medicare Part A, which is mainly your inpatient hospital and your skilled nursing. And when we talk about Medicare Part A, the average inpatient hospital stay is only 2 to 3 days. Let's face it, they don't want us in the hospital these days. It's a dangerous place full of infections, and it's gotten a lot worse since COVID came around. So Medicare Part A does cover a lot of bills, but the reality is that Medicare Part B, the outpatient services, is the majority of all care now. Starting in 2017, it turned into 52% of all care, and I bet you the number is even bigger by now. They're pushing almost everything they can to outpatient just because it's a lot more efficient than doing it in the hospital. Typically, Medicare Part A is going to cost you $0. That's where if you work 10 years and pay your taxes, it doesn't cost anything. And for most of us, Medicare Part B as in boy this year in 2020 has a standard premium of $144.60. Now that premium has been creeping up on us on the past couple of years because of what I just said. Outpatient services are on the rise. They're getting much more expensive. And as a result, that little yearly deductible that Medicare Part B has, last year it was only $185. This year it's $198. And it goes up, but it doesn't go up by tremendous leaps and bounds. But that rising deductible and the rising premium they charge us for that Medicare Part B that they either take out of our Social Security checks, or if you're not collecting Social Security, you have to send us a paper bill for them. That's going to keep going up, unfortunately, for the future. We just don't know what the numbers are going to look like each year. Ooh. So when we talked about these two paths of Medicare, Pathway 1 has been around for quite a bit of time. It is the old school Medigap supplemental plans. And then the second path was created in 2005 when they decided to start modernizing Medicare. Medicare didn't change a lick for almost 35, 40 years. A lot of people don't realize that Medicare, as recently as the year 2008, which is not that long ago, didn't cover one bit of mental health, which is astounding when you think of all the diagnoses. Why didn't they cover it? Because back in 1965, the 70s and early 80s, every state had one or more public mental health hospital systems. And unfortunately, pretty much across the board, all of them have been defunded and let dry up and blow away in the wind. Medicare didn't cover regular preventative care because in 1965, the average American only lived to 68 years of age. Now our average age is hitting up in the 92 age range, so it's a completely different world. We need our preventative care. And of course, one of the biggest problems is Medicare didn't cover drugs that we take ourselves. So in 2005, they went on a 20-year modernization effort. And most of it happened between 2005 and 11, but we're still seeing changes now. And what's nice is they spread it out over all that time period. Instead of trying to rush everything like they had to under the Affordable Care Act, trying to push it all in within a 4-year time frame, they've spread it out so far that the bits and pieces, they're eating the elephant one small bite at a time, so it hasn't been too painful of a process to integrate all these new benefits. So let's talk about the old school Pathway 1. People call these supplemental policies, but back at some point, we don't know when, people started nicknaming them Medigaps because they cover the gaps in Medicare. Now, honestly, Medicare doesn't like that word Medigap. They've been fighting it for 30, 35 years, but it's become so much a part of the language that they've kind of given up the ghost on it. Now, if someone says the word supplement or Medigap, they are referring to the exact same product. So Medicare Part A and Medicare Part B have some holes in them because, once again, in 1965, they didn't anticipate what was going to happen down the road, especially with outpatient. It's not so much Medicare Part A that they're worried about. If you had an inpatient hospital stay of up to 60 days, which I cannot imagine how big that bill is. I had a 14-day inpatient stay a few years ago, and that year was about $700,000 worth of bills. I can't imagine what a 60-day bill would look like, but all you would have to pay if you had Medicare Part A is about $1,400, which is a drop in the water in a bucket for 60 days. The problem is for the extended time periods. In the third month, with just regular Medicare Part A, you would personally pay $10,000. Month number 4, you'd pay another 20 grand. Month number 5, you'd pay another 20 grand, and then you literally run out of benefits. But this is not the one that worries us because Medicare Part A, the average stay is only 2 to 3 days. It's Medicare Part B that's the one we've really got to fill in the holes on. It has that little yearly deductible, this year of $198, and then Medicare pays 80% of the bills, and you would pay 20%. So what's the problem? They didn't anticipate how expensive things were going to get on outpatient down the road, and they never put a cap on it. Most people are aware of this. It is 20% until doomsday. So to use a personal example again, that same year where I had all those bills, $200,000 worth of those bills were outpatient. So if all I had was Medicare Part B, I would have been on the hook for $40,000. And of course, the biggest problem is they don't cover prescription drugs. So Pathway 1 came about in the 1970s. It is a blanket that lays over your Medicare Part A and B and fills in those particular holes. Now, when they first showed up, it was a brand new product, and benefits were here, there, and everywhere all across the map. Medicare dealt with that until the early 80s, and they said, look, this is getting too hard. We can't track what's supposed to be happening with the benefits on the back end. Too many different types of policies, too many different types of coverages. So we're going to make it easy. We're going to standardize it. A couple of states up north went their own direction, but in every other state of the union, including Georgia, every single insurance company has been standardized and they all have the same benefits. So it doesn't matter whether you're looking at Blue Cross or United Healthcare or 100 other different companies. If you buy a Medigap supplemental, they all have the exact same benefits. Now, when you look at this, we call this the 3-card system because you're literally, with this Pathway 1 of Medicare, you're going to have 3 different insurance cards. Your primary insurance is your Medicare ID card itself, Medicare Parts A and B. The advantage is that you get to go to anyone, anywhere in the United States who accepts Medicare. That's 100% of hospitals and roughly 90% of physicians. Medicare pays their portion of the bill, and then that's where your second insurance comes in. One of these Medigap supplementals that you purchase directly from a private insurance company. So the Medigap picks up in those holes that we briefly discussed. So between Medicare paying first and the Medigap supplemental paying second, in most cases, you've got almost 100% benefits, if not 100%. So very, very rich benefits. And then, because they didn't even invent the Part D as in David prescription drug plans until the year 2005, your third insurance is a standalone Part D as in David prescription drug plan. Because they invented that so many years after, they weren't going to retroactively mush this stuff together. Now, once again, the 2 reasons that people really like this is super rich benefits. What's not to like? Almost 100% medical coverage. And then you get to go to anyone, anywhere in the United States who accepts Medicare. Pathway 2. So when they came out with modernized Medicare, they created 2 new letters of Medicare. One that we talked about is Medicare Part D as in David, the prescription drug plans, but the other one is Part C as in Charlie, or the modernized Medicare Advantage plans. So if I was writing this on a piece of paper, the way I would look at it is Medicare A plus B equals C. That's what letter C is. It's a private insurance company being paid money by Medicare to administer your Medicare A and B benefits. And most of these plans are called MAPDs, Medicare Advantage, letter C, for the medical side, plus the prescription drug, letter D, in one policy, one package. Still 2 pieces, but they put them together into the one policy. So we call this the one ID card system because, like most normal group insurance plans you may have ever had, you have one ID card to use at the doctor, the pharmacy, or the hospital. So with these particular plans, what's happening is that Medicare sets aside to pay each person's claims, roughly about $850 to $900 every single month. 62 million people on Medicare, and that's how much money they set aside every month. Now, that's not what they spend. 85% of us hardly use our insurance, but that's what they set aside. So they looked at these insurance companies back in 2005 and said, you've been telling us for a lot of years you can do it cheaper than us. Why don't you prove it? So they don't give them the whole pot of money. They reduce it down to about $700, $750 a month. So right there, Medicare saves a lot of money to keep Medicare viable. The second way they save money is they cut themselves out as the middleman. Why would you send the claim to Medicare anymore? Who'd they give all the money to pay the claim? The private insurance company. So right there, Medicare saves more money because they're not having to process all those claims themselves. And then the most important step in this whole process is these modern plans are set up on a 5-star rating system. And they make these insurance companies jump through absolute circus hoops to go up every half star in quality. It is their direct incentive because every half star in quality they go up, Medicare returns some of that money that they took away out of the pool. So by the time you're hitting very high quality plans that are 4.5 out of 5 stars, they're getting almost the entire pool of money, which is about $850 to $900 a month. That's why these particular plans are very, very inexpensive and have very low premiums, because the insurance companies are getting paid a tremendous amount of money from Medicare to represent those Medicare benefits. Now, with this, of course, you still got to pay for your Medicare Part B as in boy, because the Medicare Advantage C is just representing your A and B and the private insurance company taking care of it. Oh, one last thing I forgot to talk about. I'm sure almost everybody knows about this. So the other difference with the modernized plans is because they have a big budget to work with, if they're truly keeping Medicare costs down, they've got extra monies to play with, which means that Medicare is allowing them to add extra benefits that Medicare doesn't cover. Medicare doesn't cover vision or dental or hearing aids and other things. These modern plans are allowed to add these extra bells and whistles. No insurance company is doing the same thing. It's not standardized. They all build different policies, but they're adding these extra benefits because it's helping them catch certain health conditions early. For example, almost every single company will do a once-a-year eye exam trying to catch glaucoma. Why? They're catching 90% of glaucoma cases up front. Most of them will add some dental. Well, they're catching oral cancer up front by the dental, but they've also drawn the links between healthy gums, healthy heart. Not every plan does this, but some of them have medical transportation. So there are vulnerable populations of Medicare beneficiaries that don't have reliable transportation. The insurance companies are thinking outside the box. What costs them less money? 36 free Uber rides a year to go to the pharmacy and the doctor and back and forth for someone who's absolutely got to see a physician, like a very, very serious diabetic. Or because they couldn't get their medicines and see their physician regularly, they wound up in the hospital for $500,000 worth of bills. Hey, the Uber rides are cheap. So this is some of the extra benefits and all the hoopla you see in commercials every October, November, early December during Medicare season, because every insurance company is trying to say, hey, on our Medicare Advantage plans, we cover this, that, and 12 other things. So when we look at how people choose between Pathway 1 and Pathway 2, what we have seen in 26 years of doing this is that people, in most cases, are literally buying them 50-50. That's what we experience with our clients. We don't push one way or the other. It really is just a preference on how you like to cover your benefits and what you're wanting to pay and how you want to pay for your bills. There's no signs that either option will be going away because Medigap supplementals are very traditional, and the Medicare Advantage plans, they've spent the past 18 years bringing these things truly up to speed and letting them mature. They're not going away anytime soon. So when you talk about how do you look at and compare, and this is where most people run into a problem. You cannot compare these two paths of Medicare based on benefits. I have a high deductible Affordable Care Act plan that's very, very expensive. And if someone came up to me and offered me one of these very low cost Medicare Advantage prescription drug plans, I'd jump up in the air together and click my heels together. But how do you compare anything versus a Medigap supplemental, the old school plans that are pretty much almost 100% coverage? It doesn't match. That's like apples versus an airline. So how we show people to make the decision, how do you personally like to pay your bills? Medigap Supplemental Pathway 1 is a good option for people who like to prepay. This is for someone who wants to go to anyone, anywhere who accepts Medicare. So it's kind of like having a network, but what a network. Yes, you pay more money up front for these plans, but when something happens, you pretty much are covered 100% on the medical. So a lot of people like that. They know what their budget is, they pay a monthly premium, and they walk away. And of course, you have to buy a prescription drug plan and pay copays for that. With Pathway 2, the modernized Medicare Advantage prescription drug plans, we call that pay-as-you-go. This is a good option for folks who are relatively healthy or who like keeping their money in their own pocket. with the understanding that the money you save, a portion of that needs to hit a cookie jar so that when something happens down the road, they can pay for those copays or other services that are provided. Now, these modernized plans, once again, they wanted to make them somewhat similar to group insurance. So they have networks. Are there HMOs? You betcha. But here in Metro Atlanta, PPO is king. These are the big preferred provider organizations that on average have about 24,000 local doctors, which is a good 9 out of 10 in greater Metro Atlanta. Usually they're nationwide networks, and being a PPO means you can go out of network as well at a lesser benefit. So the doctor choices are still there. Premiums on these can be very, very low. In Metro Atlanta, there are a lot of PPO plans that are literally that are $0 monthly because they've gotten such a high star rating. They're getting funded a tremendous amount of money by the federal government behind the scenes each and every month. This is how they're able to do it. And the reason we explained how much money Uncle Sam is paying them is because, I don't know about you, but most people hear $0 a month and their immediate response is, what's the catch? How do you have good insurance for $0 a month? It's not zero. Uncle Sam is paying them $850 to $900 a month. So with these types of plans, almost every single benefit is a copay. So if you're in your network, imagine you're in network on, for example, PPO, almost every benefit is a copay. So every insurance company has something different, but from 50,000 foot view, they're kind of similar. $5 or $10 for a regular doctor, $35 or $40 for a specialist. Have an outpatient surgery, pay a copay of $275 for the whole thing front to back. Those are examples. So it's more of a pay-as-you-go structure. And as you can see that, what if you had a bad year? Most of us, we're not going to have a tremendous amount of services in 1 year, but just like any normal health insurance under either an individual plan or a group policy, they've got to have an out-of-pocket maximum. Your worst case scenario before it can go to 100%. And so this year in 2020, the worst case scenario for any Medicare Advantage plan is $6,700. Now, this is where we have to be very careful. People go, oh, good Lord, I'm going to pay $6,700 a year. Not unless you have a really horrible bad year. Most everything is a copay, including hospital stays. It's hard to add up to $6,700, but it's possible. But it's usually if you had one of the worst year ever. Most of the time, people don't pay anything remotely near to those numbers. So the star ratings are very, very important. It is based on what we talked about briefly, the extra programs they're adding to catch health conditions for things Medicare doesn't cover. But a lot of it's the basics that we all know. How quick do they handle customer service complaints? How fast are they paying claims? How well are they managing chronic conditions? Medicare literally tracks these guys to go, if someone has bad diabetes, how good are they at helping them manage their care so that they are basically doing just as well as a person who doesn't have diabetes. They put in a lot of extra benefits to help them with this. So they track everything. The average star rating on these plans in Metro Atlanta is going to run about 3.5 to 4.5 stars. There have been a few 5 stars every once in a while, but that's kind of a rare thing. Usually one plan a year if we're lucky. Oops, skipped too far ahead. So let's talk a little bit about prescription drugs. Now, considering the fact that outpatient drugs weren't covered at all before 2005, then these plans are a miracle. They haven't kept up with the times. They do need to have some modifications, and I often teach people to, hey, give your congressman a call to tell them we need to fill in a few more holes, but they've done a pretty good job with these. So they base these coverage amounts off of what the national average of drug spending is. And unfortunately, the way Congress designed it was it has a hole in it, which everybody calls the donut hole, or is called the coverage gap. Now, only about 15% of Medicare beneficiaries ever hit the donut hole each year. But if you did, it's pretty rough, because that was a hole that they wouldn't cover any prescription drugs whatsoever. There's been a lot of improvements on that, and it was actually the Affordable Care Act that closed that donut hole, so it's been a good thing. So when you look at prescription drugs, there are 4 rungs to the ladder. The first rung, and now the information we're looking at here is for what's coming up around the corner. So Every plan can have a drug deductible of $435 or less. Some of them don't have any. They all design different products, but that is the highest drug deductible that you're going to see. And in most cases, they don't apply drug deductible to lower tier drugs, like a generic or brand equivalent. It's usually for the more expensive ones, but it depends on the carrier. The second rung of the ladder, think of it as a bucket of money. It is how much money, so $4,020 is how much money you have in your bucket. And this is how much what they're doing when they take out of this bucket is it's the cost on your behalf, but also the insurance company. So imagine it's January and I've got a bunch of expensive drugs that cost behind the scenes $1,000 a month. When am I going to run out of benefits? Right around April or May, because I've eaten $1,000 a month out of my bucket of money, and now my bucket of money is gone. That is where the third rung of the ladder comes in, the infamous donut hole or coverage gap. Now that coverage gap has been closing slowly year by year, and it was the Affordable Care Act that was forcing it to close until now in 2020, the donut hole is technically gone. Now there's some nuances to it because all those years it was closing, a lot of the manufacturers gave us discounts on really expensive brand prescriptions. Some of them took their discounts back, so the donut hole is kind of weird. I've seen some people who have drugs that are in the donut hole that are actually less expensive than when they're taking money out of their bucket, initial coverage bucket with a copay. And I've seen some people who are actually still paying a little more in the donut hole because the manufacturer took away some of those refunds or discounts and other things they were given. So there's still a little bit of nuance in the donut hole, but as of now, the donut hole is closed. And then the fourth rung of the ladder is the catastrophic umbrella, where if you reach this, the insurance company has to cover 95% of drugs. You only pay 5%. And to get there, it takes roughly about $6,350 of total monies. And it's not just your money. It's the money that was spent in the initial coverage level. It is the discounts that may be given during the donut hole. There's a lot of different numbers that they throw into that. So take that $6,350 with a grain of salt. But if you hit that catastrophic umbrella, that's where they go to 95 and 5%. Now, guys, once again, this was amazing for the time because we didn't have coverage before 2005. The biggest issue is that it hasn't kept up with the times. There are currently, and I've seen it happen plenty of times, there are oral cancer drugs that you can take, which means you take them yourself. They fall under Medicare Part B as in David that run $11,000 to $12,000 a month. 5% of that is still going to be pretty doggone expensive. So I've been telling a lot of my clients, you need to yell at your congressman and say, hey, I really appreciate that drug plan you guys created way back when, but there's still a few things that you need to fix, such as making it instead of 95 and 5%, it goes to 100% so that we have true catastrophic coverage. The other thing that I tell folks is, it doesn't matter how you feel about the Affordable Care Act. If your congressman is talking about a blanket repeal, you need to go kick him in the knee. They have to pick the gems out of the legislation, such as closing the donut hole. Because if they do a blanket repeal, it's going to open that donut hole completely back open. And that means a lot of people are going to get a kick in the budget on their drug costs. And that's not going to be a good thing. So they've absolutely got to pick and choose the nice parts and keep those. Now, some people are able to get extra help. This is actually done through Social Security, not Medicaid. It's called LIS, or low income subsidy. And to apply for that, someone can call Social Security, just the general 1-800 number, tell them they're trying to apply for extra help on prescription drugs. And if they qualify, what happens is there's a couple of different levels, but it'll accelerate how much extra help they can get. Some people who qualify get to skip all 4 rungs of the ladder, and they get to jump straight to the catastrophic level from day one of their policy, which is 95, and they only pay 5%. So in Georgia, on average, there's about 28 different prescription drug plans per county. It's the same plans pretty much no matter which county you're in. And what you're going to find is what we do is we go to Medicare's website, we plug in your list of pharmaceuticals and your preferred pharmacy. And then Medicare's website does a beautiful job of putting them all in order to tell us every single plan that's going to have all of your drugs and your preferred pharmacy and which one's going to have the best deal for you on overall numbers. Beautiful website. We always recommend that people do a review on their prescription drug plan or Medicare Advantage prescription drug plan every year. This is a simplified version of what's happening, but these insurance companies go to the pharmaceutical company every single year and they get a great deal on 4,000 drugs. How do they get the great deal? They got to purposely take a hit on the chin for 400 drugs. And if your drug was one of those 400, then hey, come January, instead of being in position 1, 2, or 3 on the best cost, suddenly you slip down to position 18 and you're spending a good $700, $800 more a year than you should have. So reviews are absolutely critical. We can do those. You can also do them at Medicare's website. The other thing is that when you talk about Medicare Part B, remember how we said it was $144.60? If you're a high income earner, you could be paying more. So high income earners can pay upwards of over $400 a month for their Medicare Part B. And if that happens, they also charge them more for their prescription drug plan. So a lot of people who are in those high incomes get surprised by that because it's not only for Part B as in boy, but also by Part D as in David. And that chart is available at Medicare.gov. We can always show people where to look that up. And those numbers change each and every year. What Social Security does is every December, you're going to get a letter that says your income 2 years ago was this, so therefore your Medicare Part B this coming year is going to be this. Where you have to watch it is for most of us, it's $144.60, but what if you have a windfall of money? That happened to my mother. She inherited a second house that she didn't need, sold it, so that was pure gains. And suddenly her premium went from $144, it was at $135 at the time, to over $400 in 1 year. And she called me in a panic. These things are, you can go to Social Security and appeal it. It's not a hard thing, but you can basically go just like we did with her. Hey, that's a one-time, hit of money. It's not permanent income from year to year. They looked at it and said, yep, you're right. And they moved her premiums back down. So if you ever get hit with that, it can be appealed. So going back to what we talked about, those extra help on prescription drugs, these are just a couple of the extra help levels. First level, they will cover part of the premium. Second one, they put you over to the catastrophic level automatically, 95 and 5%. And they also cover deductible, donut hole, and all those other phases are eliminated. So it depends on what level of extra help someone qualifies for. Most people know about GoodRx, but goodrx.com, or it's an app that you can put on your phone, is a very, very important website. At GoodRx, you can plug in your drug, and it's going to show you the free coupons for every single local drugstore. CVS, Kroger, Publix, Walmart, Walgreens, the list goes on. And what's very important about this is that about 2.5 years ago, Medicare Congress started making noise about, hey, we're going to control the drug costs. And at the same time, the manufacturers started tossing out these coupons, the same ones that you see on GoodRx, out like candy at Halloween. Congress got distracted like they normally do and said, oh, that's not so bad. Their drug costs are still fine, and they moved off to other things. It's a game the manufacturers play. Over the past 2.5 years, the coupons have been going up in price, and there have been less of them that have been appearing. And as soon as Congress acts serious again, here comes a bunch more coupons. So the reality is it's good for the consumer in that it creates some competition. You'll have drugs that your drug plan is forced to give to you for a $100 copay. But then you can jump onto GoodRx and pick up the same pharmaceutical for $20, and it's the same manufacturer. They're just playing reindeer games, and they're trying to get their money wherever they can. The other reason that GoodRx is fantastic is it will also show you every manufacturer discounting coupon that's available. It's not always based off of income. Some of them are based on low-income earners. Some of them are, say, if you have commercial insurance, so if you're still covered by a group plan at work. And some of them are studies. They don't care what your income is. They basically, you go apply at their website, it's got their web link and everything, and they say, hey, look, if you don't mind your doctor sending us results of how our drug is treating you, you get 12 months of our medication pretty much paid for free. So if you have a super expensive medication, make sure you look at the GoodRx website, plug in that drug, scroll down to the bottom of the page and you might see some very good details about how to get that expensive drug for no or low cost. So I mentioned before that Medicare has added a lot of extra things that they didn't have before. So preventative care, thank goodness, is fully there now. With the modern innovations, we're talking about the Medicare Advantage plans. Dental, vision, hearing are often available. They started adding gym memberships too. And I know that a lot of people, they look at it and they kind of laugh. Gym memberships, what's next? Free massages? But it's been proven people who go to the gym regularly, their drug costs drop down by like 20%. Obviously, people aren't going to the gyms right now due to COVID, but a lot of these they do home exercise kits, online classes, and other things. A lot of folks have heard of it through Silver Sneakers. There's been some expansion. Now, these are not for every single plan. A lot of these Medicare Advantage plans have special designs for what they call chronic or special needs, people who either are Medicare or Medicaid eligible or who just have a chronic health condition, such as diabetes. So they're adding extra benefits on those plans, and some of them are doing things like Uber coupons, covering over-the-counter items that you can purchase, through a pharmacy. Over-the-counter could be everything from a pair of diabetic socks to some Theraflu to some antihistamines. And some of them even help out with things like adult daycare, which, Medicare doesn't cover long-term care, but we're starting to see maybe some changes on that in the future. In the future, they are talking about being a lot more heavy than they are now on chronic illness management. Medicare is demanding this. They want to, if someone's got diabetes, they want them to help them coordinate their care, because the whole point is if you give that diabetic more benefits than the average person gets, it's going to keep them on the healthier side, which means Medicare's claims go down. So spend a little money today to get that person healthier and in a better spot, and all their claims go down. So that is the thinking that they're putting behind this, and the care coordination services where they try to put everything together. Most of you guys know the enrollment periods, of course, 65th birthday. The one that we specialize in a lot of times is what they call an SEP, or special election period. The phone calls we get, we're saying, hey, Aunt Martha, we just found out she's got some dementia and she's been living by herself, just moved her from Tennessee to Georgia 5 days ago. What can we do? Those are the kind of situations that are special enrollment periods, and there's a lot of specific rules on that stuff. So we do specialize in that and answering those questions and helping people figure out details. Everybody who's been on Medicare knows what's coming around the corner, the AEP, annual election period, October 15th through December 7th. A ton of information is going to hit your doorstep, and just paperwork or commercials or whatnot, but that's where everyone can take a look at their modernized plans, whether prescription drug or Medicare Advantage prescription drug, and make their changes for January 1st. And then they have a new election period that runs the first 3 months of the year, January, February, and March. These are for Medicare Advantage people. So not someone who has a Medigap and a prescription drug, but someone who has an MAPD. This is basically what I call the oops or uh-oh rule. So that if you get to January or February and look at the Medicare Advantage plan that you purchased for January 1st and you realize there's a problem. Maybe your doctor left the network, right at that same time period, and you need to pick a different plan. Maybe you found out that a mistake was made and one of your drugs is not covered. It could be for any reason, but this is where you have the ability to make a single switch for that 3-month period and pick something different. Either you can move into another Medicare Advantage prescription drug plan, you can switch back to original Medicare, just having A and B, and a prescription drug plan. They give you a couple of different options. It's a nice protection, and thank goodness they finally put this in. Started back at the beginning of 2019. Things to think about. If you are still working and you plan on retiring, COBRA is not going to be a primary benefit. It is not considered credible coverage by Medicare. So Medicare is always primary. Every other insurance is secondary. The only exception to the rule is if you or someone, let's say you're married to, is actively working for a large company of more than 20 employees. That's the only time you can say, I'm going to hold off on my Medicare, either A or B, and just wait until I retire. And what Medicare tells you in the booklet is once you retire, hey, you've got 8 months to sign up for your Medicare Part B, no penalty. What they neglect to tell you is the very moment you are no longer sitting in the chair at work, boom, Medicare became primary. So if you don't sign up for it in that 8th-month window, what happens if, heaven forbid, some big outpatient claim like emergency room or ambulance pops up? Your COBRA or whatever insurance, other insurance you have, only has to pay as a secondary or 20%. You've got to make sure that if you're no longer sitting in the chair at work, you've got to get that Medicare Part B set up immediately so that you don't get caught by surprise. Of course, if you don't sign up for Part B when you should, then it's a lifetime penalty, roughly 10% of what the premium is for every full 12 months. And the usual only way that people can delay it is if they're actively working. As long as you're actively working for a large company, 20 or more employees, you take a piece of paper to the human resources, they fill it out and say, yep, you were covered by our large group plan since you're age 65. You hand it to Social Security, and that's how you get rid of that penalty. And then the last one is a Part D prescription drug plan. They want everyone to have credible coverage. And this is a minor issue, but every year, if you've got a group plan, you are going to get handed a letter at the end of the year. It's part of the, tons of mail they send us. But in there, it's going to say you have credible coverage under your group insurance plan. Sometimes people get caught. If they get caught in some kind of plan that doesn't have credible coverage, they're going to accrue a penalty down the road when they set up their prescription drugs. So just make sure you're looking for that if you're covered on your group plan. But basically, the Part D penalty is 1% of the national average premium for every month you didn't have one. That's roughly 36 cents. So every month you didn't have one, when you buy a prescription drug plan in the future, they're going to add that much money per month forevermore. If you're on LIS, those low income subsidy that helps out with prescription drugs, they'll waive the penalties. So a lot of folks who never bought a prescription drug plan but can get the extra help, that's how they're able to get around that. We're pretty much done with most of the details. We're going to go to questions in just a minute. I'm almost finished. I'm just going to hit a couple of last small things. As you know, Medicare doesn't cover everything. We've mentioned it. They don't cover dental or vision. They don't cover what we call critical events. So most of us have great insurance. The problem is when something major happens and you're either out of work or a bunch of bills stack up because you have some kind of ongoing life event with lots of, history, whether heart attack, cancer, stroke. They don't, they're not going to pay for your mortgage or your grocery bills or something like that. So Medicare doesn't cover that. They don't do life insurance. And of course, the biggest problem Medicare has is they don't do custodial care. They do home health, which is sending a registered nurse to administer medications or to, for example, open wound care. But they don't help with the activities of daily living, such as dressing, bathing, eating, that sort of thing. So just as a quick recap, every time you feel like you're drinking from a fire hose, and you will feel like that, for most of us, it's a simple 50-50 choice, 2 paths of Medicare, and that's it. Roughly half of people at age 65 are on the Medicare Advantage, half of them are on Medigap supplementals, and you do have some abilities to switch back and forth. We know Medicare doesn't cover everything. We always recommend you do a review so you don't get caught by surprise, especially on prescription drugs. And if you're someone who's got dual Medicare or Medicaid or chronic illness, you may get special plans and offers that the average Joe doesn't get. And let's take a look at, everyone's talking about it, everybody feels differently about it, but here's a lot of the insurance companies' response to the coronavirus. Medicare is now covering lab tests for COVID-19 with no out-of-pocket costs. Antibody tests are done at no cost. These are for FDA authorized ones. All medically necessary hospitalizations are at normal cost, so you've got to be careful. Some plans are actually not careful, but it's good. They're waiving the cost. In other words, you don't pay anything in the hospital. This also includes if you're diagnosed with COVID-19 and might otherwise have been discharged from the hospital after an inpatient stay, but you've got to stay due to the quarantine. They're making sure to cover that now. Once we have a vaccine, they're going to cover that 100%. Most Medicare plans, like these Medicare Advantage plans, have waived out-of-pocket costs. So for primary care specialists, behavioral health, telehealth, they've gotten rid of their copays, no copays for the year 2020. And for members who paid some copays, they're allowing them to go back and talk to the insurance company and reprocess their claims for something they may have already paid for, dating back to the start of the epidemic. They'll send you free safety kits. They'll send you washable face masks. Some Medigap supplementals, the old Pathway ones, are providing new and renewal premium price stability and support. They're not changing their rates once a year like they do, or they're trying to make them very, very minimal. And then there are some people who have been affected by COVID-19 that they're giving them a special enrollment plan or special enrollment opportunity to change plans mid-year if necessary. So they're trying to respond to the coronavirus and the COVID-19 just by saying, hey, here's some of the things they're trying to be positive about this stuff and help out. So that's, I appreciate your time today. And that's pretty much the quick summary of the 50,000-foot view. Questions, concerns, anything that anyone wants to ask? If you guys have them, or if it's something you want to follow up with us on kind of a one-on-one basis, because maybe you've got questions about your own personal coverage, that's where, if you initiate a phone call with us, we're allowed to answer questions at that point, and we can go into a little more detail about what your personal needs or questions may be.